you know, from January of this year, we have been trying to have a series on pedagogy in medicine, and we try to do at least one episode every month on pedagogy. Professor Ravi Kant set the ball rolling a few weeks ago with his really stimulating talk on what we could do with the MBBS curriculum. So we thought it was right to have a follow-up session with him. Thank you, Professor Ravi Kant, for accepting our invitation so readily and decided to discuss on this very important topic. For those who are joining in the first time, a brief introduction to Professor Ravi Kant. He's the professor of surgery at Sharda University in Uttar Pradesh. He was previously the director of All India Institute of Medical Sciences, Rishikesh. Professor Ravi Kant did his MBBS and MS General Surgery from King George's Medical University, Lucknow, of which he went on to become the Vice Chancellor. He has done original work on lasers and breast cancer and has hundreds of publications and presentations to his credit. He has been a member of the Medical Council of India and the president of the Indian Association of Surgical Oncology. He has several awards, the most notable being the B.C. Roy Award in 2014 and the Padma Shri and Yash Bharati in 2006. The current competency-based undergraduate curriculum is one of the his pet projects. Over to you, Professor Ravi Kant. But before that, I would request Puneet to introduce Professor Avinash Supe.
I think Avinash needs no introduction to this group of medical educators. He's been at the forefront of medical education in India. It's, I think, very close to his heart. He was, I think, the chair of the curriculum redevelopment. He's donned many hats, whether it was as dean of, and director of KEM, or the, he's been awarded so many things. He's currently the director at Hinduja Hospital. And I think if you ask him what he would like to be remembered as, I think it is as the professor emeritus at the KEM hospital in GSMC, of which he was the dean and director. So he's, I think, known to everybody, every single place. When Professor Ravi Kant asked me to organize the Teachers' Day celebrations, I couldn't think of anybody better than him to address the students and the teachers actually at Rishikesh. So I think he's the ideal person for this job. Thank you.
Thank you, Puneet.
And Dr. Girijadhar Sharma doesn't need any introduction to the members of Learning General Surgery Group. He's a much loved father figure and one of the mentors of this group. Professor Girijadhar Sharma did his 4-year surgical residency in CMC Ludhiana, and he for further 3 years as a lecturer in urology and thoracic surgery. He's the quintessential general surgeon who can operate from head to toe and has huge body of work in semi-rural and not so well-equipped places, and he's a role model for many of the upcoming general surgeons. He's also run his own hospital, and his pet project is to help surgical PGs who have failed their DNB, and so he's made it his life's work to make sure that they pass the exams, and he also teaches them about work-life balance and how to enjoy life, and trauma is his passion, and his blog District Surgeon is no less than a thriller, and many of us look forward to each of his episodes. We hope that he'll be joining us soon if he's not already here. Over to you, Professor Ravi Kant.
Thank you, and thank you, Professor Puneet Dhar. You are the key person who really made me interested in this protocol and program. And Puneet Dhar is one of the wisest, nicest soul since, I would say, almost 1992 or 93, since I had known him. So let me start with this talk. And today's talk is something very, okay. Today's talk is interesting that I will come to the topic. It will be in 2 portions. Let me first explain what we want to teach, and then I'll explain how we teach. So that is how our pattern will be. So first thing is, medicine is an art and science. It is not only science. And what is happening is often we are not teaching the art. And even science we are not teaching properly. I mean, that is a very interesting, that out of this opening line, we neither teach science nor teach art to the student. And so result is, you can see today in Safdarjung Hospital, so-and-so resident had a fight with the patient's relatives, so-and-so place, there is some clash going on. And in general, there is a distrust and gamut which is going on at a very high level. So if we see that, what the Hippocrates said, life is short, art long, and opportunity fleeting, experience perilous, and decision difficult. That is what he said about art of medicine in life. Ars longa, vita brevis. That is the key point which we probably have to understand this. And Voltaire, on the other hand, said that the art of medicine consists in amusing the patient while the nature cures the disease. And that was another interesting episode. On the other hand, Osler, medicine is a science of uncertainty and art of probability. That is what even true today. So with that gamut, somehow we are confused only medicine as a drug, but that is not the case. Medicine is a treatment of a human by another human. And this component of treatment of human by a human is the key factor. So if you are not for great variability among individuals, medicine might as well be a science, not an art. Here we are focusing on, is an art based on science or science of medicine? And I consider it's an art based on science and not only science and art. So art of medicine, Cecil textbook defined as profession that incorporates science and scientific methods with the art of being a physician. So art of tending to the sick is as old as humanity itself. And similarly, Trousseau said, human elements of healthcare provider which dilute the age-old doctor-patient relationship. So it means there is somewhere that age-old relationship is the key factor in teaching, which somehow we are ignoring, and therefore there is a lot of societies having crisis among healthcare providers and the stakeholders. Today, doctors are both more powerful and more deaf, and that is the key. At least leave the doctor less naked on the wards. The key point is humanistic education has gone well, and therefore we added the Department of Medical Humanities in Rishikesh and also at other places. It became almost imperative that this is the key. So we can say that there is a concern that art of clinical medicine is dying in the present teaching setup with high-tech gadgets. In the field of medical education these days, there is not much emphasis on the art of medicine. Only one university in the world, students are recruited into medical school after they have learned music, philosophy, etc., right at the very good beginning. So is it a science? Well, that is the question is, if it was science, it should not change, but it changes every time, it obliterates. So it is obsolete so soon, so half-life of truth in medicine is short. Half of what is true today will be proven to be incorrect in the next 5 years. And unfortunately, we don't know which half that is going to be. So medical science is unpredictable. That is another point which we have to keep in mind. So there are something which changes your concept of what is the emphasis on the thing. And it's obsolete every 5 years. Management, diagnostic, etiology, curriculum is dead if curriculum is not changed in every 3 years. So it means if the educators are not alive to change, then they are dishing out a wrong food to the students who have come to learn, and that is going haywire. So that is what we'll say is the science is art, and art is science, and this combo is the medicine. That is what the focus is. So medical humanities remain a key point in which literature, art, creative writing, everything must be there in pursuit of medical education goals. If we do not understand either the creative writing or the drama or the film or the ethical decision making or the anthropology or the history, then education goals will not be met. And the art of medicine make the science more effective. That has been said by more than one person. And therefore, the concept of bioethics now is a key factor, and clinical ethics is a key factor in which professionalism, respectability, and expertise that healthcare professionals must use in respect to their patient is a key. And therefore, what is a must for universities is Department of continuous professional development. I do not call medical education because we'll be teaching other technicians, nurses, clerks, everyone. So it needs a continuous CPD is a key point, and cradle to grave is a factor for everyone from top to bottom. How to teach medicine? There are many philosophies in which, and one is this philosophy. When you are seeing in a museum and you have to write an essay and learn what was good at that time and what was not good at that. When I see this photograph, I remember American College of Surgeons published an article, 4 past presidents were shot and died. In each president of USA, what was rightly done, what was wrongly done today, as for today, and what was wrongly done even with those standards of that day. That was very interesting article. And when we see American College of Graduate Medical Education, the core competencies, what are the core competencies? When we say medical knowledge, please remember it is only one part of it. This is not the core only competence. The patient care is another way. The system-based practice is another. So this one half is and practice-based learning and improvement. So you can see that these are multiple things which we are trying to say, but they each one has a different core, and pure medical knowledge actually means nothing. Actually means you are 1/6 of a doctor. But equally important, interpersonal and communications and professionalism, because when we examine Royal College of Surgeons for either MRCS or FRCS, what we see is today that there is a significant examination on the skills examination, professionalism, interpersonal. Same at the university level in MBBS in University London, where I went as an observer. Same is the Glasgow pattern. So what we have seen is we have missed out this completely. We have forgotten about this completely. We are not focusing on this. We have very little time for this, and only we say medicine is medical knowledge. And therefore, when the students come out, they are a very, very different doctor than what they are supposed to be. When we see the Miller's pyramid, this tells you a lot of things. If you are talking about either your assessment or anywhere only about knowledge, it means you are a bad examiner, you are a bad teacher, you have hardly any concept of how examination should be done. The key point is, can he do it? That is the key point. If he can show or he can do, that is what the ideal examination would be. This will be reasonable start, but pure examination on knowledge has very little. But if it is not accompanied by attitude, skills, then I would say we do not exist at all as a teacher or as a concept of making a student. And similarly, when we go to this another one, please remember, only recalling facts are in Google. We need not focus on that. The Google will tell us. Now, ChatGPT can also analyze reasonably some of them. But factor will be, you have to create, you have to evaluate, you have to analyze, and then do on the spot what is to be done. That is where the key. Only this is not the key. This is not the key. And whereas I see then most of the examination, 90% examination is only on remember. So it means we do not know how to examine either. So outcome-based curriculum, which was first introduced in Canada, and later on rapidly, say, absorbed fairly all over the West, is including Australia, New Zealand, Hong Kong, everywhere. The key point is each skill needs to be assessed and certified. For suppose we say, when he takes water by a cup, the thyroid moves up and down. So you don't need a doctor to do, you don't need a faculty to do. You can need only a technician or a nurse to examine all your 200 students. They will not fail, but they will not pass if they don't answer. That is the key point. They have not failed if they do not answer. But that step is not complete. So each skill must have a barrier that you have to answer that. It has to be done. And that is where the key is outcome-based curriculum. You have to perform each skill, which is part of it. And this outcome-based curriculum means you have to design your teaching methodology and your assessment methodology. And that is where the blueprint work comes in. That once you are focusing on outcome, then you are focusing how I should assess it. Once you realize how you should assess it, then you realize how should I teach it. It can be class, it can be clinical, it can be seminar, it can be something else. So it can be multiple options. So quality of healthcare workers now are multi-pronged, and pure knowledge is only 1/6, or maybe I would say 10, 15, 20% of it, not more than that. We also require personal skills, social skills, methodological skills. We all understand methodological skill in terms of analytical skill, but also organizational skills, presentation skills, problem solving, stress resistance, dealing with new media. But if the empathy is not there, then you are a robot, you are not a human. If the ability to communicate well is not there, it means we are not taught them well. So if they're fighting with the patients in the ward, the fault is ours, not theirs, because we didn't introduce as a part of assessment, as a part of teaching, are they a team player? This point I find more often than not missing nowadays. This is a team player. Apart from that, personal skills. They have learned in home, they have learned in hostel, but that is what we have to make sure. The key point is inquisitiveness. If inquisitiveness is not there, oh, you are a hopeless physician or a surgeon. So all these things are as important as will be. So good communication skill are the factor which we see abroad so often, that even in examination, if the student doesn't show empathy, nobody passes him at all. And he has to do all examination again. Ability to multitask, which is a routine affair if you're working in ICU, and a good problem solving skill. That is where we have to make them sure that by our methodology, every student is taught. So what is the value of a person in a team? I consider pure knowledge is only 50% of value in a team. But if you got a curiosity, I consider 60% value. If you're emotionally balanced and you can manage a stress situation, you get 70% scoring. But if you can adapt and change, then you get 80%. But on the contrary, if you are thinking about society, irrespective of caste, color, geography, nationality, religion, oh, you are the ideal doctor in this system. So art of medicine now is a soft skill. The attitude, the aptitude, the behavior in front, and also when you are not there, no backbiting, the communication skill. And we forget that 90% of the communication is unspoken. The dress sense, that is very important. How you dress, because you're treating another human being. And the key point, again, I emphasize empathy. The example could be Spike's model for how to break bad news. Another model of how to break bad news. These all have to be taught to the student. These all have to be taught to the student so that when situation comes, they know how to do it in a systematic manner, in a very professional manner, in a scientific manner. How to disagree with senior. That is another important, we don't teach them how to disagree. If you are in a group, in a big one, and there you are saying something very rash manner, obviously repercussions will be there. So you have to realize how to show your disagreement, win your argument without humiliating the senior. That is another education. So we need integration of all the emotions, because they manifest in body as physical sensation. And we have to understand that that is a key point which we have to teach. Professionally, what is the team member? What is the appropriate behavior? What is the role and rule? What is the integrity for institution and society? And scientific bent of mind full of curiosity. The team member now has become so important in corporate world that even if you are a top knowledge person, if you are not a team member, you are not part of that corporate group. So medicine now is art of medicine rooted in the heart. If your heart is false, you will also be a false physician. If your heart is just, you will also be a true physician. So 4 elements are required: physical health, mental health, harmonious family relationship, job work satisfaction. I have seen even on when they are disturbed family relationship, it disturbs the job. If you are not well, it disturbs the job. If you are not happy with what you are doing, you are stuck somewhere. You are simply there because of salary. Oh, then you are a absolutely miserable gentleman there. So we have to understand that in a holistic health, we have to think about our conventional system, which do well. We have to make a spiritual, physical, mental, emotional, social. Each component should be focused so that you are a perfect person. So I would say medicine is an art which uses scientific knowledge and skill. Medicine is just not a tablet or capsule or something else. Medicine is a holistic approach which includes beyond allopathy to provide relief from pain due to a disease by using it in art and scientific knowledge. Now, what is a scientific word is? Means evidence-based knowledge. It is not that you can use anything which you want. And it means we have to focus on prevention a lot, which we are more in therapeutic mode. The prevention component is going low down in the priority. So in science is an intelligent hypothesis, and our experiment proved that we are correct, but replicable elsewhere, universally. On the contrary, faith has got an intelligent hypothesis that I pray in this temple or a mosque or a church or somewhere else synagogue, and our prayers are answered well. So I'm in a way blessed, but that prayer may not be replicable elsewhere. So the faith and science differ on this point. So evidence-based medicine is integrating individual clinical expertise and the best external evidence. So I would stop this slide here by going to the next point now. And let me go. Yeah, I will come to focus again on this point, that please remember, simply expert opinion has a very little meaning. You have to go to meta-analysis for that. But now let me stop this and go to my second presentation so that we can be there. Question to teachers. Those who know, do. Those who understand, teach. That is a very old thing. So it is an important thing. Now, our prevention of NCD or major non-infective diseases has almost been, in a way, people are not focusing on what should be done because what the community needs. That somehow the curriculum has got haywire. This has to go on this one. Evaluation strategy. How we assess. This assessment has to change every 3 years. And we have seen in COVID that we needed a different strategy all the time. Do the students have curiosity? Can they have a research aptitude as well? When we were working in London, I realized one young MBBS student has come from Germany. They had a 6-year course. And I said, what are you doing here? He said, in our university, it is mandatory that 1 year I take off from that university, go to some research lab and work on research and only come back. And you can imagine he's left the Germany program as a mandate, came to National Medical Research Center in London and was working on a newer project. So that aptitude we have to build by an inbuilt system as a mandatory component. We have to also promote out-of-box thinking. Whatever is happening today is not enough. What is the out-of-box thinking going on? And if curriculum, if it is not realized, we can say it is at dead. We know that if you are appearing in USMLE, close to 30% questions come from psychology and psychiatry. Why not psychiatry is a special exam? When we see dermatology, so much the need of society. Anywhere you go in village, anywhere, dermatology required. Why not we create dermatology as separate?
Your experience between clinical exam sequencing and whole exam sequencing. I mean, like, what was the additional need of doing a whole exam rather than a clinical exam?
Say it again.
Yeah, so we'll take the questions in the answer. Sorry.
Okay. So my point is the curriculation, we have to decide what is the need of the society. Let the need of society be reflected in our curriculum. Whether it is psychiatry, whether it is dermatology, any subject, let's create them as a separate assessment study. Who are the leaders? We will go soon. Who are the next leaders? We have to give them assignment. Now, this is the problem, solve it. And we have to make them sure that they do it well. So we can be a person who are, say, there to make sure the whole team becomes the next CEO, the next vice chancellor, the next dean. And I have seen that once assignment was given, the team rose to the occasion significantly. The measure of the intelligence is the ability to change. If you can't change, oh, you are a deadwood at all. So we similarly realized what is the internship? When I was in Northwestern University, Chicago, I realized there every MBBS student who is posted in a unit was doing what our interns do in India, right? So it somehow I thought internship is a useless thing because the MBBS has been designed in a bad way. And the key point there was that, and therefore there's no internship in some of the universities abroad. And we have to think about, when we are thinking of curriculum, are we talking world standard or are we talking Indian standard? If multiple courses are not inbuilt into the system, oh, we are talking about a very obsolete curriculum. What is wrong with our examination? That is another point. Why it is so much biased? We say private school give more marks or government school give more marks, and so teacher gives more marks to so. We are seeing these accusations very often. What has happened that in 100 years, we are not able to solve our own problems? Who will solve our problem, if not us? I don't understand this point. Can we reach at the door of the poor? They are the stakeholder. The rich will go anywhere. They can go fly to New York. They can go anywhere. But can we reach the door of the poor and serve them? That's another thing. Can the student also dream of the world beyond textbook? That is another point which we have to initiate. That student group have to be encouraged. That whatever in textbook is obsolete already because it was published 5 years after it became well known. So the textbook is not the answer. You have to think of newer points, newer facts beyond that. Are lectures by teachers sensible anymore? We have a data that 5% is the retention data of lectures. So why are we say on focusing on lectures in a university? What can be or sorry, not lecture but lectures. So we can do a flip class, we can do a problem-based topic discussion, we can have many other methodology, the peer learning methodology. So these lectures are obsolete and must be done. Each skill be certified. That is what I saw in University of Arizona. Each skill is certified. Who certified doesn't matter. It may be technician, it may be nurse, it may be just clerk, it may be your porter who is saying how you behave with the juniors. So it can be certified by anyone. But they have also got 200 students. Each skill is certified for each student till that he is not allowed to appear in examination. But he does not fail if he is not certified. He's just not allowed to appear in exam. So there is a very interesting system how we should go on. How many students should be in one clinical unit? The Northwestern University, Chicago has a standard that one student in one clinical unit. There is each faculty is a separate clinical unit. They have also got 200 plus students. And therefore, it is very important. So unless until you've got 400 clinical faculty, forget about pathology, forget about anatomy. Please don't carry 200 students. You need student clinical ratio to be so good that he is there as a clinical clerk, as a surgical assistant, and not as a student, where he'll be assisting in each thing which is done. And we organize this thing reasonably well in Maulana Azad Medical College for good almost 15 years. So that we used to have, suppose there are 7 or 8 postgrads in one unit. So one student is attached with one postgrad. Postgrad means those who have done MS examination. So what community needs is competent doctor. You can imagine a surgery problem has gone to emergency. He wants to show to surgeon, but there is a junior doctor and who is not competent. So what is going to happen? Clash will happen. So we have to somehow understand who is competent and how to organize the competency that is apart from your procedure skill, cognitive skill, and social skill. And therefore, I would say, what is the blueprint? The list of the skills desired, how to teach each of these 500 skills in surgery, and how to assess each of the skill and be certified before you appear in final exam. And how to teach medicine. I have taken same photos again to emphasize the point that ACA GME remains a standard model all over the world, and Miller's pyramid remain understood, a basic line for the teachers. And unless until we are focusing on analysis, evaluation, creation, our teaching is not done. So outcome-based curriculum, these points were hammered earlier. Value of person again. That this is we learned this point from the corporate world, that how we rate a student. So key point is attitude, and this we have already done. And now I would say, as I close to a conclusion, that clinical vignette must automatically replace MCQ when you are preparing the exam question. Pure knowledge-based questions are crying. Reasoning analysis is mandatory component. And how many questions should we ask? The answer is very simple. University, Canadian University, for final licensing exam, the American University licensing exam, American University asks, basically, American board asks 1,800 questions, the Canadian board asks 2,000 questions. So why ask only 100 questions or 50 questions? In a clinical, I have seen the viva is a fountainhead of individual bias against race, gender, English language skill, kinship, absolute fraud in a practical exam. This viva is the most dangerous thing, where I have seen so much bias clearly visible. And therefore, the very standard answer is we must focus on OSCE, not anything else. Thank you. There I end, and I'm ready to answer the question as you said, and we'll come to meanwhile go where we finished there, and we'll come to where I stopped so that we can go for. So I'm ready for questions at this stage.
Thank you, sir. Over to you, Dr. Avinash Supe and Dr.
Oh.
Girdhar Sharma. Sir,
Thank
if
you,
you
thank
don't
you.
mind, you can stop sharing your screen, sir.
Just give me how much time I had taken? 34. Give me 5 minutes more and let me finish.
Yeah, great.
Just
Okay.
a minute.
No problem.
Okay. So finally, we realize what is the modern poem is patient-oriented evidence that matters. This all science will be required in medicine. Every one of this chemistry, space, atomic, nuclear. So you can imagine that nowadays, whatever you are seeing on the screen, whether medical physics, everything, each of these components are now essential in science. The mathematics, the space technology, telehealth, the biotechnology with the so much DNA and mRNA, the digital technology, right? Simulations, digital medical educations, tele. So all this thing is now a modern medicine. And therefore, IT has become an essential component. And we have to understand that now every component will be there apart from artificial intelligence. So we are thinking about science. When we talk about science, these are the all subjects. And if we realize what is happening in real life, allopathy cures only 25%, control another 25%, palliate another 25%, but we have nothing to offer for remaining 25% disorders. So like Ayush, etc., I think we must explore in a very evidence-based medicine and hope that this leadership program and leadership model gives value to the students, and a milestone is not a destination. And we have to realize that life is really it's not so straightforward, and learn throughout the life. Okay. I found this to be very interesting in the wards. When someone is shouting, he may be literate but not educated. Okay. And that is my last slide. End of the day, when you are not well, when the chips are down, the family supports, nothing else. And each component is important to make sure that you are a good doctor. Thank you. I will now stop the bell thing. Okay. Pause sharing.
Sir, open your Zoom and then stop sharing.
Yeah, I said that. To that, to stop sharing. I said that to stop. I mean, it's saying resume sharing, it means I stop.
Okay. Thank you.
Yes, sir. Yes, sir.
Welcome.
Thank you, sir, for such a excellent talk. I think you brought up so many important, relevant points for the today's education. Like you started with wonderful quotes, and you said that we need to change towards humanity teaching and more professionalism and skills. You also talked about need for personal social skills. You also talked about out of box thinking and innovations. You also talked about bringing in psychiatry and leadership, reaching to the poor, and also you talked about artificial intelligence and technology. I think vast topics which you really covered, and are so relevant today that the curriculum is changing every 3 to 5 years. I think now what we'll do, we can open this for discussion, and then we will ask sir whatever questions. I think anybody has any question. Already Anshu has raised a hand. So Anshu, you can start actually.
Good evening, sir. Good evening, everybody. Let me congratulate Dr. Ravi Kant for talking about a topic which is very relevant to all of us, how we can integrate humanities into the present curriculum. I remember when I got into medicine, people used to tell me, this is the wrong profession for you because once you join medicine, you will not be able to write. You will not be, you'll forget your poetry. You'll forget everything that is creative about you. Unfortunately, I didn't have to go down that path. But when I see the present generation, especially students from even 9th and 10th standard, the way they are thrust into coaching classes, the way they have to go into the competitive mode, it kills a lot of the creativity. It actually numbs down everything that is sensitive about you. And the process starts much before medical school. That's a sad part about how our assessment system has become such that we end up numbing down people's sensitivity. When you look at the way we have our examinations, they ask you questions which are not important when it comes to the humanities aspect. So my point of here is that when you ask people questions in the examination which are clinical and which have no which are not pertinent at all with the humanistic aspect. These humanities, even irrespective of how much you teach them, will not make a mark because the student is focused on the examination. The second point that I would like to make is what we are talking. You mentioned that subjectivity is a problem with assessment. I beg to differ with this, because any of those things that you talk in humanities, whether it's communication, whether it's teamwork, whether it is professionalism, they cannot be measured objectively. The only place you can measure them is day to day, where there is an expert who's observing you. We again have hurdles in the medical field where we have large numbers of students and increasingly lack of faculty with the number of colleges increasing. So unless you have somebody observing students individually and giving feedback day to day, this cannot be done at the end of the year examination, that you give feedback about how a student is communicating well or not. This is something that you do daily in your wards. So there are these problems which come in. One, the number of colleges increasing, the number of students per batch increasing, and the number of faculty is minimum. You will stick to your minimum standard requirements, where managements are not keen on employing more faculty. So we are stuck in this vicious cycle somewhere. And I think the answer to that is to look at the existing opportunities that we have. One, wherever you're posted, whenever you catch a student doing something wrong or doing something right, it is important to give feedback right then and there, because that is how you catch the opportunities you have. You talked against Viva, but I think Viva is important, except that we are using Viva to ask the theory questions again, which is wrong. You can use the same Viva to give students hypothetical situations, asking them how they would react to a particular ethical issue or a crisis management issue, and use the same Viva for different purposes. So given the existing circumstances, I think we need to change our view about how we can use our existing uh, uh,
Fine.
tools that we have and use it for humanities. Thank you so much.
Fine. I think your point is well taken, Anshu, that you can use your tools, but what Sir was trying to bring out was, agreed, means all this is, we are ultimately leading only to the knowledge-based exams. We need to bring the other component, skills and professionals, into all our assessments. And if you bring it effectively, I think the whole thing will really change into that whole system. So you want to respond on this, Professor Ravi?
Yeah, I think the first point was about medical humanities. We consider that organizing cultural programs and various classical art programs or other modern Zumba dance program, they are so important. And the reason is very simple. A surgeon, as I am, normally deals with sadness throughout the day. Someone is dying, someone will not be cured, someone will be cured. So the whole day, someone is taking your sadness, happiness away and leaving sadness there. It's like exchange. So when in the evening we go to some art and cultural program or to some sports program, that is when we bring back our happiness and in a way balance our life. So it's very important. So I would say it's a very important system that is there. About the second thing, I have seen Viva. I'm a faculty since '84. I have seen nothing more than this ghastly weapon, which is used against majority of the student to either just give them 54, 55. There's no, you have to standardize question. What do you want to have? Standardized question, automatic computer based. On this patient, okay, moving or not. Let all the 10 patients, students answer same question. And we learned this thing in Delhi in 1983 as a senior then, that is how we can do exam. So we have to change this. Not a desire to change is the key factor. Thank you.
Sure. Anybody else has any question? Dr. Sharma, you want to really ask any question or comment?
Dr. Girdhar Sharma.
You're on mute.
Yes, sir. Sir, we are unable to hear you, sir.
We can't hear you, sir.
So there is a bandwidth problem.
Yeah, I think we are not able to hear to him. I think one of the thing which I always thought when I was a student, and now when we are trying to do curricular reforms, that as Anshu rightly said, our program, and you also said, sir, our whole curriculum is too knowledge based, and that also at very low level knowledge we are asking. I think said 300 questions of MCQs which are very low. One of the key thing is to change to higher level of questions where, as you said, case scenarios or clinical situations, add clinical decision making into that, as well as during our formative and internal assessment, bring the workplace based assessment where we test the skills and professionalism. I think it has to be a complete cultural change in our country, which will bring a lot of changes which will happen. I think Sunil wants to ask something. Would you ask Sunil what is your comment, or you want to ask question? Sunil Joshi.
You have to unmute the mic, Sunil. Right. Carry on, please.
Sunil. Okay. I think we see a lot of other people like Puneet
Sir,
and
can
Patta.
if I can
all
just
of them
interrupt,
are-
I think Dr. Sharma could be heard now. Sir, can
Hello.
you speak? Yes, sir,
Good
we
evening.
can hear you now. Yes, sir, we can hear
Yeah,
you.
good evening. Very interesting discussion, Professor Ravi Kant. I would like to raise 2 points. Number one, for last decades, when I talk to the young, bright and smart postgraduates, I ask everybody, would you like to be a teacher? The answer is big no. What is your thought process on this? We are not attracting the talent to improve our next generation towards the faculty. Let us forget people who are already in faculty at the age of 50 plus. What is your viewpoint, Dr. Ravi
I
Kant?
think simple one reason is remuneration, cash in hand, nothing else.
So,
If
all
the
these
cash in
things,
hand, like I'm answering Girjaji. If the cash in hand to my professor in London used to be 3 types. He was getting one salary as professor in University of London. That was 1x, same as everyone. He was getting double of that salary as professor of clinical gastroenterology. Then he was getting another big salary as a professor of research because he was running a national medical research center. So he was running on the Gower Street, the clinical gastroenterology unit, the research unit. So he was getting almost 4 times the salary of professor of history in University of London.
So very true, very true. I fully agree with you.
Similarly,
Yep.
similarly, Dr. Supa, I would say when I went to Saudi, I realized my many friends had gone from AIIMS Delhi as professor and who were more on non-clinical side. They used to ask, what is salary? I said, that's the only question you don't ask. Because I was getting 3.5 times compared to what they were getting, because my component included hospital, research, administration, and they were getting only university side.
Sure.
My answer is done, sir.
So
So
that is the
that-
first. What was the other comment, sir?
my second comment is, if this point I've raised many times, that anybody who is a postgraduate teacher must recertify himself every 5th year.
It's a rule, sir. Everywhere abroad, it is a rule.
But
Yes.
people tell me when I talk about, I specialize in DNB teaching. And when I tell people, they say then the all DNB programs will collapse except 2-3%.
So even in
Sir,
Delhi Medical Council for recertification, you have to have certain points which have to be proven. So
Sir, actually, our recertification should be much more better and much more should be deeper. Only those 30 points has no meaning, according to me, for 5 years. But I think at least it was the first step where we at least asked for recertification. Ideally, we should have some, because the knowledge is changing so fast, we should at least every 5 years or 10 years, we have to undergo some kind of a proof of training or proof of some assessment where we show that our skills are valid. Otherwise, I've seen people with their poor skills treating patients with very old methods when the new, better methods are available. And I think this is a response. This is a problem to the society also.
Dr.
So it's
Sube,
not only recertification.
Dr. Avinash, if I say correctly, in US, every 5 years, you go for points-based recertification.
Yes.
Every 10 years, you give examination again.
Yes.
For Anshuji, before I invite Sunilji, Anshuji, your last point, See, the examination system in America is formative system. The formative assessment is the key. They gave scoring of 70 to 80% on formative and only 20 to 30% on summative. And formative means on each step you're correcting, you're not failing him, you are just saying you're not passed. There is a difference between two. One is you have failed, one is you are not passed. It means you do it again and there is no crime done. And same way the American KG class student learn how to read a book. They score certain percentage, they pass. If they don't do, they do it again. Sunilji, welcome.
Agree, sir. Fully agree with you. Sunil, can you ask your comment? Can you give comment
Yes,
or
yes.
ask question?
Certainly, sir. Sir, are we talking about UG training program here or a PG training program? That is my first question.
We are teaching both. Same concept, same everywhere.
Okay. So the question is,
I'm primarily focusing on UG. My 80% talk is for 85% talk is for UG.
sir, like Anshu said, the training for the future courses starts from the 9th or 10th like that. Similarly, in MBBS, the students are much more interested in writing a PG exam and getting into some PG course rather than learning something. So there has to be a contribution from the students as well. Students' intensity, what they want to do, how much they want to learn, whether they like it or not, they're interested, will all depend on what incentive they have for the future. Like our PG exams, entrance exams, instead of being knowledge-based, if they can become more clinical oriented or humanities, like you said, like OSCEs and other things, that will probably make them more interested rather than if they have exit exams or the entrance exams as knowledge based, they will not be interested in attending to all the things that we're saying.
You want to answer this question, sir?
I would leave it to Dr. Supe to answer this point because this is something which is very well done in US, that PG seats are 1.5 times of UG seat. So nobody is dying for a PG seat.
See, actually, Sunil, the problem with us is we, as you rightly said, though we are increasing number of seats, the quality of those seats is a problem. So everybody wants good seats. And the exam, which is only knowledge based. Next is on the way, but biggest problem of next is if there is a clinical component into the next, how are you going to bring uniformity of selection in that next clinical component? So if you're going to select people on next, then that clinical component has to be standardized. Now we are struggling with conducting basic exams. So when you add an exam like next, there'll be a MCQ component where we can raise the level by bringing clinically based questions. But where is the other clinical component? It will be uniform, but there are not so many teachers, so many centers, there's so many issues which we are going to face if we bring clinical components. So I think we need to transform more into formative kind of assessment where all these components are built in. Till the time he is done, he is not allowed to appear. Now, this is a hard decision. You know, that's, I think somebody has to say. So I think you understand that point. That's the whole issue here.
Got it.
Dr. Sharma, you had said something. What did you really say?
I am trying to say I have been through such a system in CMC Ludhiana, where the points to select a person out of 150 people, 12 residents were taken for 6 months. And Dr. Eggleston made it clear that selection will be based on your availability, aptitude, conduct, dexterity, and the last point was knowledge. And it was made clear with a pyramidal system, out of 12, 6 will be thrown out after 6 months on these criteria. After 6 months, 3 more will be thrown out. After 6 months, 1 more will be thrown out. When at my time and all of our time, we could do 6 months in medicine, 6 in surgery, then 2 years either in medicine or in surgery, right? He made it clear, 4 years, one has to minimum work in surgery, then take the logbook to boss. Then after looking how many APRs, he says 5. He says 2 more come in the winter. He says, hell with Punjab University. If I let you appear, you may pass accidentally, because he said the examiner only wants you to tell the lipoma slips under the finger. whereas you may not be able to catch that bleeder. So there, that was the tough system. And anybody who passed 5 years had automatically ingrained all the qualities. The problem is today is where we have lot many professors of surgery, where are the teachers in surgery who feel pride in having their students better than them, who will stand holding retractors like American system, where the professor holds a retractor. Here, either the students, and we have so much of diurnal variation in surgery in India. The boy is not fit to do an incisional hernia in the morning list, and he is competent to do a liver injury at night. Don't you agree?
Yeah,
I mean,
absolutely. I agree with you.
we don't want to get up at night. That at the night, 2 a.m., we say, very good, pack and come out, right? So I think our age people can only change. Government will not change.
Okay.
If we have the fire, if we owe this much to the next generation, because our generation teachers did for us. That's my viewpoint.
Oh, you know, sir, what is my worry actually? I actually gave a talk on hyposcilia. I think the way we are expanding in our country in a postgraduate education, we are creating a generation of people who are having poor skills for some period of time unless the system stabilizes over a period of time. We have grown so rapidly in last 5 years. We have doubled the seats without increasing infrastructure, without increasing number of patients. And I think one teacher who had 3 students now has 6 students. I think it has been a little chaos. So I think it is our individual conscious we have to really say, but I don't know how much it will be across India, sir. That's my problem. As you rightly said, some medical colleges have excellence, but there are many who really are still struggling to achieve those skills. And this is where, how do we achieve uniformity? That's our basic problem today in PG education, especially in surgical branches. I think there is Puneet and Patta I can see. Can you have your comments on this, Puneet or Patta? Radha Krishna?
Yes, Puneet.
I think it's a very, very important topic, and I think we definitely need change. And how we bring about is extremely difficult because of so many, problems. We don't have uniformity across the country. It's a state. Health is a state subject. Education is a state subject. How do we get uniformity? And that's one of the things which has plagued us forever. I feel the biggest problem roadblock we have is the teachers themselves are most resistant to change. And unless, I think one of the slides I really loved in Professor Vikant's thing where they said that, you have to, if we don't adapt to, the new technologies, new media, new everything, we are not, when I was moving from Cochin to Rishikesh to Delhi, everybody said, how can you change at this age in your life? And I realized actually that's what kept my brain active. So I think we need good role models. We had fantastic role models. I think we need to be good role models and say that the Audi or the BMW is not more important than, the thrill. I've seen in GI surgery when we hold these teaching sessions, every single faculty is so keen on teaching the students. I'm so amazed that they're not worried about the money and all that, So I think there is something inside that you want to change the world. So I think they should want to change themselves and then change the world as well. The other problem we have is that the MBBS and even PG actually, like Sunil I think said, has become an entrance process. So the MBBS, I saw my son through the 5 years actually prepare for the PG entrance. And through PG, I see him worrying about what is going to be the, the super specialty. Exactly. Yeah. So like Professor Vikant said, the best way out, and we actually have a model in the country is the Defense Forces. AFMC has, I think, 130 seats or something, but the number of PG seats is 200. So they actually have to take outside people to continue with the PG so people can get their choice. And, next is one way out, which I still think is a very good option because it does end up standardizing the whole country. I know what you said, the challenges about the practical bits. But one beauty about it I really liked, like the West, is it avoids the immediacy, it gives you some flexibility. In the West, for every level, like if you're going to go for a PG, the entrance for that is not immediately before that, the 5 days before the starting date, which we have in India. It is 1 year or 2 years before. In your sophomore year, you decide what the super specialty will be, etc. So, so the exam planned at the end of MBBS rather than at the moment, the exam after MBBS, and then internship is completely redundant. Every kid is only studying for the PG, the NEET exam. So the next being combined with the NEET has this potential to actually make the internship itself relevant again. We were lucky, I think we were the second last batch of the 2-year PG where we had to have a house job before the NEET exam, the entrance exam. So we even, internship was completely utilized. I still remember a lot of my stuff. I'm not sure the current undergraduates have that thing. So that the second model is the Eggleston and, what even PGI followed, as Dr. Sharma was saying. Before we send for the exams, we should certify as teachers whether the kids this is for the PG, of course, whether the kids are suitable. And I don't think any of us have the guts to do that really. Like Germany, many people don't pass out till the chef decides. Agreed, like the YY, it has a bit of subjectivity, but I think there should be objective criteria we should build into for that subjectivity. In fact, at the moment, it's completely the reverse. Sometimes we feel it's a measure of our pride if our candidate is not going or passing or whatever. It shouldn't be. We should make sure. And like somebody said that the numbers game, Anshu, I think, said that the numbers game, we are, it's very politically expedient to increase the number of PGs per teacher, which is not helping us at all. I don't even, I've listed everybody in my phone book as MCH first year, even after they become almost a professor. So because I've forgotten, I would forget their names otherwise. So I think very, very important. I think one of the ways we can change is this fora, and that's where Radha and Ilango and Vidya, we all sat down and had a discussion as to, we should bring about a change in the thought process, bring about sensitivity with people. Only then we can push change with people like Avinash and Dr. Ravikant at the helm of,
Punipat, very well said. I think sensitivity is one of the most important thing which we need to bring. The only comment I want to make is, Punit, those who have Audi, BMW or Mercedes don't attend such sessions. Radha, you want to say something?
Very interesting conversation, sir, and it's so nice to see so many luminaries here. Of course, as Punit is saying that this thing, the medical education, the quality of medical education in India is really bothering us. And some student got annoyed when we wrote about this, that saying that the quality of medical teaching and learning is coming down progressively in the last few years. And now, what surprises me is what Professor Ravikant is saying, that cash in hand is the thing for good teachers to be in teaching. But there are very, very good teachers, say 2 decades ago, 3 decades ago. They didn't have much cash in hand. So I don't know what made them teach, what made them to be legendary teachers, which is not there now. What exactly is missing? Because when we said that, when I commented on that, the students also are not interested. Even the students are not playing their role. Somebody got very annoyed, saying, no, you can't find fault with students. They are very new. They have no idea about what to learn, what not to learn. It's the teachers who are not inspiring. I want Professor Ravikant to comment on that. That is cash in hand a real incentive.
Yes.
Before I get on to the
very
next one.
simple. I saw, if I remember, who were the great teachers. One, they insisted that you learn one physical sign every day. And time slot was very simple. It will be 6 to 8 in the evening. So there were, we used to have 2 attendants, A and B. If either is absent, then you are absent for the whole day. The B was the evening, and A was from 8 to 4 p.m. B was 6 to 8. And it was for all students, all MBBS students, with no exception. So that one physical sign per day made sure that we learn. Now, question is about cash in hand. I saw my chief used to come in Mercedes S-Class. Almost all of them used to have very, very beautiful clothing, suits, matching summer and winter and everything. all of them had good practice. They all were earning much more than the average society. They all were doing very well financially. And I saw that good teachers were only those who were making good money. Those who were making bad money were very bad.
Secondly, I mean, I don't know, I may be wrong, but I find the best of students are in the public sector and the best of clinicians are in the private sector. I mean, there's a huge mismatch. How are you going to bridge this as an educator and someone who's propagating newness into medical?
One of the things we must really all consider that we have seen a tremendous technological change. See, it was a time few years ago, somewhere in 60s and 70s, technology used to come to the government hospitals first. But today, it has completely changed. The technology comes into the private college. So, the technology is rapidly changing. So, most of the new things, you will always find good clinician working on this new technology in private sectors. And government colleges are slightly lagging behind, except for few major institutions who are able to cope up, with the budgets and all. But common government hospitals are not able to cope up with technology. Because they don't have technology, I find them are not able to cope up unless they make a separate effort on their own to go out and learn. Now that's, I thought, is a major game changer which has happened over years. So I think if government wants to run government colleges effectively, they should also see that the technology is brought, people are trained, there are opportunities for people to grow in their career. Then only I find the good teachers will come from the government sectors. Otherwise, currently, many teachers I find are not interested. They're all in private practice outside. They're not interested in teaching because they feel there is no technology. And there is so much of issues into the government hospitals. So this is where I feel...
Professor Avinash sir, I would say that during Maulana Azad, my 20-year stint, I went abroad not less than 7 times, all times sponsored by government. So there was no dearth of that.
So central institutes have a very different
all
way.
machines for the latest, and whatever was the latest in the market was there in MAMC and GP Pant, come what may. So that was one thing. Second thing which I have seen, even in AIMS now, it is a right to visit abroad. It is not only a, say, favor, it is a right to visit 5 meetings in India and 1 visit abroad is almost a right, including a business class ticket for professors. So Professor Punithar went to Guatemala and to Latin America. So I would say that is still there. It's not absent. The key point, two problems are there. Where is the money? Who pulls the money? Answer is taxes. Who pays the taxes? Answer is those who pay the taxes. How many pay the taxes? Answer is 12% only or 10%. So if the money is not there, the government cannot spend. So there should be alternate answer like insurance or something. If you don't solve the money earning angle, you cannot expect money spending angle to be solved.
So I think
we spend only 1% of GDP on health in India compared to 7 to 9% in China and Brazil, and much more in Scandinavia.
1 minute, I would like to slightly say that, see, central institutes like AIMS, MMC, PGI, JIPMER have a lot of budgets. Look at the other 200-300 government medical colleges. They don't have so much of a budget where people can really go. That is another one point. The second point you said about GDP, which is very true. Actually, if you really say, once one of the IS officers told me very nicely, he said, look at the tax to GDP ratio. Now, there are some countries like Scandinavia where the tax to GDP ratio is 55%, in which case they take education and health totally on the government and they give the best care. Countries like ours pay only 10% tax for stuff the GDP, and therefore education and health is privatized. And that's what happened after 84 or 94 when the liberalization came. And that's the reason why I find most of the government sectors were not kept up to date. And that is the basic problem why we have issues in these medical colleges also.
So my next point is when we have standing examples of good medical education and standardized exams in the UK and the US and Germany or Australia, why aren't we aping them? Why aren't we sort of duplicating them? And why we have such loose and unfair or very dilute methods of teaching and examination? Why can't we just copy paste?
Dr. Patra,
I think
Puneet can say that we have been able to do it exactly as is done in the West.
there are some examples.
That is aims
Yes,
restricted, sir, but why not all over the country? If
see,
you have
actually, when they started NEET, I think about say 5 or 7 years ago, they started NEET with Prometheus and the international kind of an standard. But there was some leak of those question papers by some people, by engineers, IT engineers, and that really spoiled the whole system. And we went back into our routine MCQs, which were prepared by our people. And when our people started preparing questions, they were very low level MCQs. So I think when we are trying to bring system, which is a good idea, what you really said, that if you bring ready-made systems and contextualize to us, it would be much better rather than trying to revise or bring everything, devise our own. But I think we need to have that kind of an systems, ethics, security to bring all those. That's where we are losing. We are not really.
Avinash ji, the fact remains, American board sells their own papers, and they also advertise well that 25 to 30% questions will come from old papers only. Reason is, when you are asking 2,000 questions, even if 800 or 700 questions are old, the new question are 12. So these are voluminous data.
Sure.
So we were focusing in AIMS Rishikesh, same thing, 200 questions each paper. So anatomy 2 paper means you answer MBBS answer 400 questions. So you have to learn the topic. You can't get away from it. Like
True,
MS surgery, MD medicine, 200 paper questions each into 4 papers, plus 50 questions per month into 3 years. So total is almost 3,000 plus questions. So we can change in the given system. Nobody is stopping us. Simply there is a lethargy and lack of teachers like Dr. Avinash Supe and more clinicians and everyone who are best but not teachers.
Agree.
Exceptions are Puneet Dhar and Patta.
No, you are right, sir. There is definitely there is a
Avinash?
scope for changing. Yes.
Yeah. So
Who
I
is
think,
saying?
yeah. So a couple of points. One is that I don't think it's such a bad idea if, see, our aim is to have the students know the answers. So if even if they know those questions, it's just that instead of having a 2,000 strong question bank, if we have a 2 million strong question bank, and they know all the answers, that's all that we want.
That's
So
okay,
if they
we
know
want.
those answers, at the end of the day, we want them to know the dose of a particular drug. So that's one point. The second is, so I mean, rather than the fact of we are making them. I've seen some people who are kids who are studying for the NEET. They are so good. They know 5 classifications for colorectal cyst, which an MCH person doesn't need to know. And 6 months later, I cross-question them and they don't remember a single one. So, that's meaningless. So whereas if we have the system that we keep asking from the same set and keep checking, and eventually they will remember it's going to be hardwired into there. So that's one point. The second is we talked about how the best, what Radha raised a very, very pertinent point. And I think it's a very easy solution we have. About the best students being in the public and the best teachers being, I think we definitely need a public-private partnership in teaching. At least we're already seeing that in conferences, because I organized the national board webinars for GI surgery, and practically every I think 75% of the topics are covered by private non-teaching institutions. So it's not at all. I think all of you have taken sessions for that. It's not at all, we can utilize the best talent we have without spending an extra penny. And I think MCI is slowly moving to that. Apart from the AIMSs, they've permitted a certain percentage. I just saw a ruling a couple of months back that they are permitting some people to come in. We should actually encourage that. Dr. Ravi Kant had, visiting professors and, from abroad, people coming in. A lot of places, AIMS Delhi has a lot of people as visiting faculty coming in. We should actually encourage Unfortunately, we have the caste system deeply rooted, private, public, teaching, non-teaching. I think it's ridiculous. We need to get away from all these divisions and utilize the best talent where we have and encourage it. So I found a lot of people in the government sector threatened by somebody coming from outside. Some people who are forward thinking encourage that, whereas others who are negative thinking do, feel that they're going to be left out. So I think we need to rethink those things.
Puneet, when I use this word adjunct teachers into GAMR, no, I had so much of discussion. I had to face so much of criticism. But then we said, yes, we have to allow people to have a wider section coming, and even for a short period of time, for a short segment. But if they have the expertise and knowledge, let them deliver it. No, knowledge can come from anywhere. The skill can come from anywhere. I don't think we should be so rigid. And nobody gets threatened by somebody coming and giving a talk to you. No, actually, I think you yourself get inspired as a teacher also.
Now,
Yes, Patta, you have anything more to add? Comment?
Yeah. See, when will a day come when a 35-year-old capable person will head a department and not a 57, 58-year-old, who may be, not that qualified, or just years and seniority is the professor. And,
Patta, that is happening today in Saudi Arabia. More often than not, head of department is either assistant professor or associate, but not three professors who are there. They say you are too highly qualified. You focus on your teaching or work and let this routine work be done by assistant or associate professor. So even in US, if you see, the PD selection, which is supposed to be more sensitive work, is done by assistant professor as a program coordinator, not by professor, not by seniors. So this has been, this delegation of authority is worldwide, and same thing is happening gradually. I would say what Puneet Dhar can do, I would never put my hand in that and say, do whatever you want to do. My agenda will be this.
Very true. Dr. Virender, you put capable. What do you really want to say? Can you speak out?
That Dr. Radhakrishna told capable 35-year-old. That is our capability, the question mark.
Yeah, I mean, there are so many examples of somebody being a chair by sheer, knowledge, publications, ability to lead. There's so many things which are counted on. Because why I say this, I see places where the head of the departments can't speak English. I mean,
yes.
They've been in a rural sector for 20 years just because they just come onto this. Suddenly they become HOD. They may not do many operations where many other assistants can, but they also, in some instances, will not allow the juniors to do. I've seen all that. I don't know the name, where and how, but that is the sadness of the whole thing. You become a HOD surely because of your age and experience, nothing to do with your knowledge or capability. I hope you understand what capability means now.
Yes, that's a hierarchy system.
Right.
Yeah, I think, Patta, many good institutions have a rotational leadership.
Yes.
Many of them have 2 years or 3 years to take away the administrative load, and then others, then you can spend more time in teaching and research. This is also a good method, but ultimately, many institutions have, like Puneet said, St. John's, then I think Jipmar has one all. The question is, ultimately it is one person also sees that the faculty around me also grows. So I think that's what also Dr. Ravi Kant said, that you have to really see that the faculty grows also holistically. It's not only teaching, but in your own department, if you're a HOD, you would like to see everybody around you would grow holistically in personal skills, social skills, capability, and ultimately that's where the leadership and management comes into picture. I think this is some of the, when we started this FAMER faculty development program, I think I would send one. Recently we published in Academic Medicine our 20 years of impact of FAMER. So ultimately, if you see, as a teacher, when we are growing, as he said, medicine is a small component as our thinking. We have to think about practice skills. We have to think about teaching skills. We have to think about leadership skills. We have to think about social skills. And we have to also see how you build a personality around in that. And that makes a big teacher or a great teacher. So I think these skills have to be built in in your department. People do indirectly or directly. So you have to really make it formalize and make this leadership and management programs, educational leaders. I want to talk about academic leaders. We need to develop those academic leaders, and that will probably bring the education.
Avinashi, if you see the Saudi Arabia,
Hmm.
at age 60, you retire as a clinician, but you can be hired again for another 5 years if you can do something for medical school, something separate other than your own core subject. At age 65, you retire unless you do something else for university. So that way, the people, those who 60 to 65 or 65 to 70, they have to give extra more than their core department to the system in order to survive there.
Sure. Very true.
I just like to make a point that this rotating head is not really what Patta is talking about, because it will be the 4 or 5 professors are the ones around whom the rotating head happens. I don't think the assistant professor is picked up to be a rotating head, but probably we'll get there someday. From having just one head all the time, we've moved to rotating head, so probably they'll start inducting younger people also soon. So yeah.
Okay,
Very interesting.
Vidya, let me do simple mathematics. When you enter at 18, by 23 you pass MBBS. By 26, you have done the MS. Another 14 years. So 26 plus 14, age 40, you are professor even in AIMS. But if you're in a state college, it is 26 plus 9. So that is 35 or so somewhere. So exactly what Patta is saying, that will happen. I can guarantee that with the current system. The pure mathematics.
Yeah, good to know, sir. Good. That's assuming that everyone gets their PG and everything and moves on fast. So if anyone has any other, Dr. Venkatesh, did you want to say something? Dr. Venkatesh Natarajan?
Ma'am, I have a question. One of the problems, one of the things for the teachers is that nowadays people are asked to publish in order to get a promotion. Is this a good thing or a bad thing?
Venkatesh, can I answer this question for you?
Yes, please.
I think it was somewhere in 2006 or 7, I was in one of the committee where we recommended that we should have these 4 publications for professor and 2 publications for associate professor. I think it is very important the way our country reacts to all this. They lose the sense of that whole document, and they just try to follow the absolutely document. Some 800 journals have come up in last few years, which are not so quality journals, which have come in India, and they're all paid journals. It has become more of a business, and the whole concept of people publishing to become a professor was totally different, and what ultimately happened was totally different. So I think it should be good. We can say predatory journals or whatever. I mean, Anshu, thank you for that. But what I would suggest is we should have, there was recently one paper came to me for review. It was saying, what is the academic status of our leaders in our institutions? So they have analyzed good institutions, and they found out what were the academic status, H indexes of people, publications of big institutions, deans and HODs. So the whole question here is that they should not have only numbers. You should have the quality publications, something which will be a good quality research, not necessarily innovative research all the time, but at least they should have sense of going ahead. And if they have this, I'm sure it is useful. If you are going to have the current system of these predatory journals, it is of no use. So we should have better quality indicators, especially to monitor them. Okay, best 5 publications could be one idea. You can really look at it. But see, many people don't have 2 publications when they become professors, sir. That's what I've realized. Many times the posts are vacant. You want to promote somebody, they say there is no funding. Dr. Venkatesh, we have so much of clinical work. You may not be able to do basic research, but clinical cases, we have so many. I mean, I don't see any reason why you can't keep a record and publish. I think which is something which we should not really see. So worldwide, if it's a best 5 publications, yes, but there has to be some quality indicator.
Thank you.
Looks like that it is.
Yeah, yes, please go ahead.
Yeah, ma'am, but looks like that the idea of publication is really degenerated into this kind of poor quality, poorly thought out, and sometimes I find some of the postgraduate students have to pay out of their pocket for even
Sure.
for such publications. So
Yeah,
it's a kind of,
very
I think
right.
there should be an
But you have to
upper
pay
limit
also
out of
for the
this.
PLOS, which is one of the best journals. So paying
No,
is
you
not
have to
the
pay
point.
for so many journals, sir. Actually, if
See,
you really see,
in
there is
the best of the journal, if they are not raising advertisement, they have to get money. So paying is not the problem, but paying without peer review is the problem.
Dr. Venkatesh, see, this problem came in US also. If you really see, in 95, they brought this concept of scholarship, and they brought these 3 scholarships, and they said that discovery is the only way of scholarship. So then they brought integration, they brought application, and then over a period of time, they got scholarship of teaching. And now scholarship of teaching is necessary, or that can be included as one of the teaching professor's criteria. So scholarship of teaching, I'll send you our 2 chapters which we published, where the scholarship of teaching is now so important, which can be alternative for publications. So if you have concentrated yourself as a good teacher, you have made a lot of efforts, then it can be considered as good scholarship, and it can be considered for your promotional aspect. You need not then you do junk publication like people are doing, and spending money and everything. It's all junk information which is coming, which is of no use to anybody.
Not only
Thank you,
junk,
sir.
sometimes there is something that is done by the work that is done by somebody else is credited to somebody else, or the person who actually did the work is the last author, or I mean, this whole thing is a quagmire. So we have to find some way out of this. So thank you.
See, Chat GPT is coming. Chat GPT is coming. Now you will have a new series of publications.
I can tell you on a lighter note. When I joined AIMS, Shikesh, one of the departments collaborated, and we had a publication which was done mostly by a person who'd actually left the department by then. So, but his name was not there in the publication. So I pointed that out to that department, and they within a week had another reprint with his name on it. When I looked at that,
oh my God!
hang on. When I looked at that publication online, it looks so authentic. It's amazing how predatory these publications can be. That thing actually doesn't exist. There's a number, there's a page number. If you go there, there is some other article there. So we have to be very, very careful about these predatory journals. So Professor Ravikant was very keen that people should engage in research and have publications. But I saw the flip side where the people before their APR things, they were desperate to publish. So a lot of these predatory journals benefited from that. But we also started the Journal of Medical Evidence there. We have the National Medical Journal of India. We have plenty of journals which are free to publish, free to read. So I think we should increase our own impact factors, and instead of only sending it to the Lancets and all that, we should enrich our own literature. It's very, very important that we increase our own impact factors. We are partly responsible for that as well.
Puneet, somebody recently sent me free journals list. So I'll forward that list to you. You can forward it to many others. I think I think we are on the last slot, but I think I would like to ask Dr. Ravikant one important question. He said psychiatry should be special subject. I really appreciate that. I think there has been a lot of demand. 15% of our disease patterns are psychosomatic or psychological, and we only spend about, say, 15 days in psychiatry. So do you really sincerely think that we should concentrate and make a psychiatry as a full subject?
We reshuffle, and in AIMS Rishikesh, psychiatry is a professional examination, dermatology is a professional exam. Separate, you have to clean it. ENT is a separate professional examination, not part of surgery. So we made sure that all these departments are given strength and armor, because society will need all those points to be understood. And as a general practitioner, we are not going to ask you hi-fi. We just want you, what is neurosis, what is psychosis, what is the treatment here, what is the treatment here, right? But this was a professional exam, so we created many subjects professional examination where you pass independent and not linked with medicine, not linked with medicine. So dermatology, all things became. I'll send these publications to you.
I think the demand, the PG number of PG seats should be dynamic. We have a list in the NEET which is ridiculous. Everywhere in the world, it's a dynamic list. So if we feel we need more, pre-paraclinical teachers, we should increase those numbers. But when I looked last year, the KEM, the list of PG seats, there was 1 seat for psychiatry, 5 for pharmacology. So I thought with a mental health pandemic in the country, we need the exact reverse.
We are dynamic in aims, Rishikesh. Whatever the society need, those JRs were given in that department.
Puneet, me and Anand Krishnan had done one paper in 2012. It's published in NMGI. You should read that. We had calculated the number of seats and we had calculated the disease load and pattern in India. And we realized so much of discrepancies there. There are 1,200 CVTS seats and we don't have now so many operations for CVTS. These are the branches which are not doing well because see, all cardiologists are taking their cases and people are struggling and they're doing, I know all this. So we should really dynamically reduce those seats and increase seats in areas where there's more. So absolutely right in all this. But, the whole process is so complicated, all this. It makes very difficult for somebody to increase 5 seats. And so what everybody is worried. If I call for inspection again, my even 1 seat will go.
Professor Ravikant, and I just, as you are talking, this thought struck me. Would autonomous institutes be able to do that? Like, yes. To change their
yes, they should do it. That's their whole aims, and JIPMER are doing it anyway.
Dr. Vidya, we have already done it. We are not showing what we should do. What I showed you on the papers was what we had done, not what we should do. It is after we created the separate psychiatry as a professional exam in MBBS, then this paper was published.
I was referring to the PG seats, but your point is well taken, sir.
Oh yes,
so would you like to sum up, sir? Would you like to?
We are given suppose 200 or 300 PG JR. Which department they will go depends on director.
Sure. So I think Vidya, thank you so much for inviting me, and I think it was a pleasure really talking to these great intellectuals. And Dr. Ravikant, your talk was just excellent. You brought a lot of points which were very relevant. I like especially medicine is treating of a human by another human. And I would add that treating a human by another human in a humane way. I think that could be one of the best way we can put today medicine as it is. And also, as I said, changing the whole perspective from purely knowledge based to skill and professionalism and humanities is probably need of the hour. I think we discussed a lot of issues about the assessment, outcome-based curriculum, then importance of the personal skills, social skills. We also made a mention about out-of-box thinking innovations. We try to think about how we can, technology is coming up in a big way and we should try to see that the teachers get upgraded. But I think the most important point is to trying to create an inspiring faculty and keep this faculty positions inspiring and create new teachers, as Patta rightly said. I think we all need to really put all our effort to see that at least we create new teachers and try to bring this curriculum back onto the track for what we really need as India rather than just producing numbers. I think that would be the take-home message I thought we could think. So thank you so much. And it's back to Vidya, whatever you want to really say.
Thank you, Puneet. Thank you, Amnaji. Thank you, Girijaji.
Thank you, sir. Thank you so much.
Thank you, Pattaji, who is the coordinator of the thought.
Thank you, everyone, for joining and staying. And it was such a wonderful interactive session. I'm really, grateful to Puneet for having put me in touch with Dr. Avinash Supe, and thank you to Professor Ravikant for continuing to be integral part of Marvelous Medicine. We'll meet again next week with another episode of Marvelous Medicine. Till then, take care and stay safe. Good night.